right ventricle sometime. Now coming to pathophysiology, how the failure propagates further failure. You have high PVR and high pressure in the right ventricle. Normally, the right ventricle and pulmonary artery have a nice coupling system, and when the pressure goes up, this coupling system is lost and there is going to be RV dilatation. As I said earlier, when the dilatation increases, the RV wall stress increases and the demand supply alters and there is reduced coronary perfusion, RV ischemia happens and RV output is reduced, which leads to reduced overall cardiac output. This is on the pressure side. From the volume side, due to tricuspid or pulmonary regurgitation, there is going to be high volume overload which aggravates the tricuspid regurgitation. There is high right-sided filling pressure which leads to edema and organ congestion. This is on the volume side. When the tricuspid regurgitation increases, this invariably leads to R dilatation and the pressure effect also takes effect. Apart from that, there can be low aortic root pressure. And here now, as the pressure increases, the right coronary artery perfusion is limited to systole. Previously I said it receives blood supply during systole and diastole. As the pressure goes up, the right coronary artery perfusion is limited only to the systole and ischemia can develop and there can be compensatory tachycardia. And coming to left ventricle, there is ventricular interdependence. Your septum is pushed towards the left ventricle and there is ventricular septal shift, reduce LV preload, which also reduces the RV preload. This is the pathophysiology of failing right ventricle. Now coming to the workup of the patient with right ventricular dysfunction. First is history and physical examination, which is what are the various factors which are suggestive of right ventricular failure. Then the classical electrocardiogram and chest X-ray. You have to look for cardiac biomarker, but the gold standard is going to be your transthoracic echocardiogram. In the echocardiogram, you look for LV failure and it can be due to acute MI, left-sided cardiomyopathy or valvular heart disease. Here, you have to do both left and right heart catheterization. It can be a right ventricular failure with an increased PA pressure. Here, you can look for pulmonary embolus, pulmonary hypertension, congenital heart disease or a lung disease. Here you have to do right heart catheterization, evaluate the lung, chest CT and ventilation perfusion scan and cardiac MRI. You can have RV failure without increase in pulmonary artery pressure, where you have to look for RV infarction, valvular heart disease, right-sided cardiomyopathy or a perioperative RV injury. Here you go for right and left heart catheterization and cardiac MRI. And you can have pericardial disease which can contribute to reduced cardiac output. Here you have to do a right heart catheterization and cardiac MRI. Now coming to history and clinical symptom,